Okay, let's talk about syncope. Let's first talk about it in the context of someone with Parkinson's disease. People with Parkinson's disease have autonomic dysfunction, and it can lead to neurogenic orthostatic hypotension. Patients with Parkinson's can experience some lightheadedness or syncope on standing or coming up from supine position. The technical definition of syncope is when a patient has more than or equal to 20 millimeters of mercury drop in systolic blood pressure when standing and an absence of the expected increase in heart rate. In a normal, healthy patient, standing from a seated or even a supine position will naturally trigger arterial baroreceptors and it increases sympathetic drive in the patient. What you have is vasoconstriction. You start to move the pooled venous blood from the legs and you have an increase in heart rate in order to aid cardiac output. When a patient has degenerative changes to autonomic ganglia or even CNS nuclei, especially in Parkinson's, what you have is autonomic dysfunction that leads to neurogenic orthostatic hypotension. What you experience is a failure in the increase of norepinephrine, and then you have consequent failure of vasoconstriction and increased heart rate, and that's when your patients fall. Because you don't have this natural response, you have that more than or equal to 20 millimeters of mercury drop in systolic blood pressure. On top of that, if I have a Parkinson's patient, they have dopamine agonists as well in their system, such as levodopa, which can also further contribute to orthostatic hypotension. This is usually because of the mechanism of action of dopamine in peripheral vessels, which causes vasodilation. There are many other causes of orthostatic hypotension and syncope, such as primary adrenal insufficiency, but remember that these always come with electrolyte abnormalities like hyperkalemia or hyponatremia. On top of that, when a patient has hypovolemia, you would still expect to see an increase in heart rate that's expected in a regular orthostasis mechanism. If your patient experiences syncope after an activity such as shaving or putting on a necktie, remember that this can also be carotid sinus hypersensitivity. It's an exaggerated response triggered by tactile stimulus of the carotid sinus. There are also medications that can cause orthostatic syncope, such as vasodilators with alpha-1 blockers or antihypertensives in general, and even inotropic or chronotropic blockades such as beta blockers. To recap everything, orthostatic syncope can be caused by medications, like I just said, hypovolemia if you have volume loss, and autonomic dysfunction, which can be a consequence of predisposing disease such as diabetes or Parkinson's. Not to mention, advanced age can also contribute to orthostatic syncope caused by autonomic dysfunction just because of the natural process of aging. There are two other main causes of syncope called reflex syncope or cardiac syncope. The carotid hypersensitivity I mentioned earlier is a type of reflexive syncope, but cardiac syncope and the other elements of reflexive syncope will be covered in a different video.